Thank you for making the time to listen to this presentation on the SureflO2 indicator, which you may be trialling in your theatre suite over the next few weeks. My name is Matthew Matusik. I'm an anaesthetist and developer of SureflO2. Before I start talking about the device itself, I thought that I might take a few minutes to give you some background around the potential pitfalls with existing oxygen therapy systems. Specifically, I'm referring to one of the oldest, most simple oxygen systems that we use every day: the disposable mask and the source from which it derives its supply, a portable cylinder or a fixed wall outlet. We're all used to seeing these simple systems used in the perioperative period. Most importantly, during transport of patients from theatres to PACU post-operatively and during early recovery in PACU. The provision of supplemental oxygen during these periods is regarded as normal standard practice. But what's the rationale behind this additional use of resources and expense? Well, in the late 1980s, several studies assessed the consequences of managing patients postoperatively without supplemental oxygen. In this example, 95 ASA 1 and 2 patients were transferred from theatres to PACU on room air only. 35% of these patients were found to have SATs between 86 and 90% on arrival to PACU, and 12% had SATs less than 85%. Given our understanding of physiology and anaesthesia, it makes sense that patients who have had sedatives, general anaesthetics, narcotics, muscle relaxants, blocks, transiently do require high FiO2s, as their respiratory mechanics and gas exchange takes time to return to baseline function. This is why most postoperative hypoxic events occur during the first 5 minutes after arrival in PACU. The thing is that whilst transferring patients on room air leads to hypoxia in a significant proportion, what's worse is transferring patients that have been fitted with an oxygen mask that hasn't had oxygen flow activated for whatever reason. In these instances, not only are we not providing the intended 40 or 50% FiO2, the patient is not even receiving room air as they reprieve the hypoxic hypocarbic mix from within the mask, which is unreplenished. In 2019, an audit of 511 surgical cases at a large tertiary hospital was performed. A covert anaesthetic nurse was used in theatre to observe the workflow around the provision of supplemental oxygen at the end of surgery. This nurse would then follow the patient out to recovery and observe the transition of oxygen source from the cylinder to the fixed wall outlet in PACU. Any period of the mask fitted to the patient with no oxygen flow for 15 seconds or greater that went unnoticed by the anaesthetic team was deemed an error. The anaesthetic and or PACU team would then be informed of the oxygen supply issue so that the problem could be rectified. Overall, 6.3% of the cases observed had an instance where the anaesthetic or PACU staff thought that oxygen flow to the patient's mask was active, when it in fact was not. The majority of these events occurred when the mask was first placed on the patient in theatre. Most frequently, cylinders were either not turned on or the tubing not connected. In addition, there is still no ideally designed oxygen cylinder. In fact, newer designs that are marketed specifically for their safety still lend to errors. In 2018, the New South Wales Government Quality and Safety Committee released a safety notice in response to numerous reports of user error with the new integrated valve regulator cylinders. The common report was that the user may believe oxygen is being delivered when there is in fact no oxygen flowing. In the UK in 2018, the NHS Improvements team released a patient safety alert titled "Risk of Death and Severe Harm from Failure to Obtain and Continue Flow from Oxygen Cylinders." Review of their nationwide adverse event database revealed 400 critical events, including 6 deaths due to incorrect operation of portable oxygen over a 3-year period. That being said, whilst these events happen, they don't always lead to a significant adverse outcome. Here's a typical risk man report. We recognised that the patient's oxygen cylinder had not been turned on during transport from the operating theatre to the recovery room. The patient SATs were 88% on arrival to PACU. They came up to 94 within 2 minutes of correcting the oxygen supply issue. The patient's SATs then returned to 98 over the next 3 minutes. Often, we might regard these events as no true harm or near misses and not report them either because of time pressures, acceptance, or fear of self-incrimination, given the sense that it was our role to ensure that the oxygen was on. These, however, should be regarded as drug errors, as medical oxygen is classified a drug and reported on RiskMan in the same way that other drug errors are. These minor errors also reduce PACU efficiency, as in this case, the patient required an additional 5 minutes in recovery for their oxygen saturation to return to 98%, which is what it should have been on their arrival if the oxygen had been correctly activated. Why do these events happen? As I mentioned earlier, there's nothing overly sophisticated about the equipment that gets used for this type of oxygen therapy. If any of us were given a Hudson mask and a cylinder and asked to activate flow alone in a quiet office, we'd get the job done correctly every time. The problem is, we don't work in a quiet office. We work in a time-pressured, cluttered, and busy environment. We frequently have to multitask, move in limited spaces and use equipment that doesn't really accommodate the ergonomics of our workflow. In these settings, we are prone to human factor errors. By way of an example, this is the typical vantage point of the anaesthetic team when transferring a patient from theatre to PACU. We are limited in our ability to easily confirm that oxygen flow has been turned on at the cylinder and continues during transport, given that cylinders are usually placed underneath or at the foot end of the transport trolley, and we simply just can't see around corners. So our current best practice is to put the mask up to our ear to listen for hiss of oxygen flow. This is still not ideal. Some flow regulators will continue to deliver a few seconds of oxygen flow even if the main cylinder valve is closed. Background noise such as that of suction may give the false impression that oxygen is flowing when it isn't. Listening for hiss is a once-off check and doesn't safeguard against errors when oxygen cylinders become depleted during transport. Finally, leaning over to listen for hiss of oxygen flow once the mask is fitted to the patient potentially places staph within exhaled viral plume, which has been shown to extend out to 40 centimetres from the patient's airway when a Hudson mask is delivering oxygen flow at 6 litres per minute. So getting close to the patient's airway to confirm that oxygen flowing isn't a good idea. Ultimately, considering the current workflow limitations of these systems to simply confirm that oxygen flow is active, the most obvious design adjustment was to incorporate a flow indicator at a position that is already the focal point of our attention in normal work patterns, at the mask. This is the premise of SureflO2. This Australian-designed and manufactured flow indicator provides healthcare staff with a conspicuous cue to the presence or absence of oxygen flow into the mask. It has been developed through collaboration with aerospace, design and mechanical engineers, human factor specialists, anaesthetists, and perioperative nurses. In the presence of oxygen flow, a bright orange signal is revealed within the indicator. In the absence of oxygen flow, the orange seal is concealed. Maximal exposure to the orange signal occurs at our standard default flow rate of 6 litres per minute with less exposure at lower flow rates. It supports flow rates of up to 70 litres per minute. So if we look to aviation for a similar example, when coming into land, pilots have to multitask and have a list of important things to do, deploying the landing gear being one of the most important. The thing is, rather than having to stick their heads out of the window to confirm that the landing gear is in fact down, they simply check their console for lights which indicate that this has been done. The SureflO indicator is based on this same engineering principle. allowing busy staff to simply look at the indicator, which can be seen from up to 9 meters away, as a signal to confirm that oxygen flow has been activated. One of the most commonly asked questions from users is, why is the indicator orange? The choice of the signal color within the indicator was governed by human factors specialists. As the purpose of the indicator is to draw the attention of observers, signal colors that blend into the surroundings would be least ideal. Human gaze is attracted to areas of difference. Theatre environments are typically filled with objects that are blue and green in color: surgical drapes, gowns, walls. In this setting, orange is the complementary color to these backdrops, standing out the most and in turn drawing the attention of observers. Additionally, there are other risks to remember when providing oxygen therapy. Fire is an important one. There have been several recently publicised operating theatre fire events, typically involving superficial head and neck surgery performed under local anaesthesia and sedation. Use of diathermy, which is an ignition source, in an oxygen-rich area is the usual culprit. This risk is well acknowledged, particularly by plastic surgeons, and was addressed in a 2019 issue of the Australian Journal of Plastic Surgery. One of the key recommendations in this article was that supplemental oxygen to the patient's mask should be ceased for 60 seconds prior to the use of diathermy. The incorporation of the SureflO2 indicator during these cases enables better management of oxygen therapy, as the indicator alerts the surgeon and entire scrub team to the active flow of oxygen, prompting enhanced control prior to the use of diathermy. You can review our collection of risk literature by visiting our website. And if you have any feedback or questions, please email us at info@sureflo2.com. Thank you.